and really enjoy getting to work with him on the many, many issues that he covers under human services, which hitting, I think, is the most important part of the budget. And I'm sure that all of you would agree. Mike's been an analyst with Senate Finance since December of 2015. He's responsible for providing the analytic support for Health and Human Resources, Subcommittee on Budget Issues concerning healthcare, social services, behavioral health, intellectual disabilities, and substance abuse services, disability services, public health, and aging services, and I would add to that CSA, which is a huge part of the budget and of interest to all of our members. Prior to joining the staff of Senate Finance, Mike worked for the Virginia Department of Planning and Budget for more than 15 years, and he was responsible for development of the governor's budget for his assigned area, monitoring and executing the final budget, and developing fiscal impact estimates on legislation proposed in the General Assembly. In his last 10 years at DPD, he was primarily responsible for the Medicaid budget. Complicated, as we talked about. He has a bachelor's degree in public administration from Virginia Tech. And a master's degree in public administration from the University of Delaware. Go Blue Hens, right? And so I'd like to present Mike Tweedy.
Okay.
Thank you all for having me. I'll probably walk around a little bit, 18 seconds. But I still have to manage this button, so hopefully I won't mess that up. So Jen already went over a lot of my background, just to give you an idea of why I should even be up here to talk about any of this stuff. I don't know why Jim won't cover this stuff, but he tells me HHR is too complicated. It's like, well, yeah, but but I appreciate being here. It's sort of, I think, what I talk about is within HHR. So I'm going to talk about Medicaid. And of course, Medicaid doesn't really directly affect locals except for the eligibility side within social services. But it'll give you an idea of why it's so important in the state budget. So I'll try not to get too much in the weeds. It's very easy. Because I'd rather kind of get to the end where I could actually take questions. I prefer to have a back and forth rather than just talk at you. So feel free to stop me if you have a question while we're going through this. I did want to add before I get going to is like, when I was at Virginia Tech and I was a senior, I actually did intern in the Roanoke County Budget Office, so I had a little bit of local experience. So I did that for some, I don't think that's from Roanoke County is here, but it was actually a great experience. I learned a lot. Budget director at that time was Brent Robertson, who I think is the county administrator of Franklin County, if I remember correctly. So anyway, but before I talk about Medicaid a little bit, just the major budget highlights for 2019 for Health and Human Resources. So you probably already read the paper about the Medicaid forecast. I'll talk about that more in detail as I go along. Medicaid expansion, probably from a local perspective, kind of the savings that were assumed for community services boards, you've probably heard about, a lot of concern about that. So I'll talk a little bit about that as well. There are other impacts of Medicaid expansion, tweaking, there's the waiver to do a work requirement and things of that nature, which could be tweaked depending, because there's different interpretations about what some of the language means. So there are little things there. There's the exactly what was the provider assessment. So if you recall that basically the ongoing 10% state share of Medicaid expansion will be paid for by private hospitals through an assessment on them. And so there's some questions about what exactly is that amount. So of course the private hospitals want to pay as little as possible, but so that there may be some of that discussion too. And then there's also community behavioral health services. This has been a priority of the General Assembly the last few years. So continuing to invest in that as well is going to be there. An issue. And then the census pressures in state mental health hospitals. So in 2014, when state hospitals became kind of the bed of last resort in cases of crisis and through temporary detention orders, there's been kind of a shift between private hospitals to the state hospitals, and that shift has basically pushed their state hospitals to their maximum capacity. And so relieving that pressure is absolutely essential because otherwise those hospitals will be in crisis as well. So this slide, pretty much this kind of, to me, tells it all about within the state budget. So what it basically goes back to is if you go back to the mid-'80s, Medicaid was at about 5 to 6% of the state general fund budget. It has grown to, as you can see, and this chart is actually like over a year old, but at that time, the budget for FY18 had Medicaid at 23% of the general fund. So if you look over that time, every area except for public safety has a smaller share of the pie. So higher education within the context of the state budget is really discretionary. Very important, but discretionary. And you can even see to some degree K-12 education as a percentage of the pie has changed. Now of course, the total amount, the dollar amount of the two pies is very different. And of course, for anyone who's a budget person or a finance person knows that the only way you could otherwise fix something like this is you could make the pie bigger. So you could increase taxes or generate revenue in some other way to try to deal with the growth of Medicaid. But it puts a lot of pressure on the state budget, and it will continue to do so. So like I said, the Medicaid forecast. So every year there is a expenditure forecast of Medicaid. It is basically the single largest program in the state budget. I'm not going to go into grand detail about this, but $463 million over a 2-year biennial budget was required by this forecast. That's in addition to the $576 million that was added in last year's forecast. And I'll show you in the next slide why this number is a little bit unexpected. And we shouldn't necessarily be seeing it all this year, but we are. The growth rates you see at the bottom of this chart, so you can actually see the 2017 forecast was the previous one. It actually had growth rates of Medicaid of 2.5% and 3.4%, which are very low growth rates for such a large healthcare program that does as much as it does. And there's a reason for that I'll get into in just a minute. And you can see the new rates bring up FY19 to about 6.2%, and then the next year to 2.6%, which looks a little bit low, but the outer years, the savings that comes from Medicaid expansion actually depresses it. So you kind of have to factor that out to get a true growth rate of that. So this chart, and I'll try to explain it very quickly, but I like it because it kind of highlights the unexpected nature of what has happened in this forecast. So in every 2-year budget cycle for the state, Medicaid will be there. The forecast will forecast the 2-year period essentially 3 times. Before what we did last year, prior to the biennial budget, or the biennial beginning, this year, which is when we're amending the 2-year budget. And then the last, which is the red column, is what we call the caboose budget. You come at the end and you have to adjust the second year for changes in Medicaid. Because Medicaid has so many changes, we have to adjust it every year. So what you can typically see here is the blue bar, which is your initial budget, is always your largest. And that makes sense because in a 2-year budget cycle, when you start looking at your next 2-year budget, you don't have any growth built in for Medicaid. Medicaid is a program that grows. So you have to build that growth rate into it. And so initially your 2-year budget, you'll always have a large need in that first part. And the amended budget, usually you're making changes for different things. The last time we had a significant change in the amended budget, which is the yellow bar, was 2008 and 10, but that was following the beginning of the Great Recession. So naturally, there would be an additional need there. So if you jump down to all the way to the right side, 2018 through 20, you actually see the blue bar is kind of smaller than it should have been, and the yellow bar, which is the $463 million, of course, is larger than what we've seen in a long time. So, and there's a reason for that. We should have recognized a lot of these costs in the previous forecast. And I'll explain to you kind of why. So this very general, if I had more time, I would have put general fund revenues in that, because really the issue with Medicaid is when you look at general fund growth rates over a period of time, Medicaid typically always grows faster. This is just showing the Medicaid program. In FY 2010, Medicaid is highly sensitive to its enrollment. Enrollment is its primary driver. So after the Great Recession, by 2010, you see 13.5% growth in the program because enrollment was skyrocketing because of the recession. And then you see that it comes back down a little bit as the recession as those enrollments decline, it actually drops to a fairly low level. But probably since about FY 2015, it's averaged close to 6%, which is lower than its traditional growth rate. When you go before the Great Recession, it tended to average about 7 to 8% over time. It's actually a little bit lower now, and that's generally because national healthcare costs are a little bit more depressed than they used to be. And then you can see the value growth rates there that are projected. I'm not going to go into great detail about this chart because there are always things that drive Medicaid, one-time things. We have a very large federal repayment we have to make because Air Piedmont and Catawba Mental Health Hospital is no longer qualifying for Medicaid. And so they're expecting us to pay money back that we paid to them. There are always things that you have to recognize within Medicaid every year. So that's not unusual. We would have expected to see some need because of some of these things. The one that I talked about really is the right side, the managed care rates, the red part of the pie. It's almost half of the need. And the reason why is, and the state has moved its Medicaid program to managed care, where we basically pay private health insurance companies to manage people's care for us. We have 2 managed care programs now. Quite simply, the difference between them is that one of them serves primarily children, a cheaper population, and the newest one serves basically disabled adults who are basically the highest cost beneficiaries in our Medicaid program. So between those 2 programs, we have to set rates every year. We have to pay the companies more. The rates have to be actuarially sound, and so there's a rate adjustment every year. And what I'll talk about is that the new program, the rate assumptions were lower than they really should have been. And this slide kind of tells you, basically what it says is last year for FY19 and then 20, respectively, was a 2.4% and 3.5% growth in what we call the CCC Plus programs, the Commonwealth Coordinated Plus program. It's the one for basically disabled individuals and elderly people as well. And so those assumptions were basically the idea that when we moved to this new program, we would generate a lot of savings, that you would be able to prevent admissions to nursing homes, maybe even move some people from nursing homes to the community, and ultimately the state would receive savings. There were different reasons as to why they made those assumptions. They were very, very aggressive, and as we thought at the time, and it's proven to be, were unrealistic. And that's what I said. These rates could have been, in the previous year's forecast, shown to be higher, and then the budget for Medicaid would have been higher and recognized those costs. So you probably would have seen, you wouldn't have seen $463 million this year. It probably would have been like in the 250 range, a much smaller number. So just to kind of cap off talking about Medicaid, so the question is, from just a pure budget standpoint is kind of the current forecast what it should be. And these are just kind of 2 of the risks that, from a staff perspective, I think is still there. Even though the managed care rates are much more realistic, the one program is so new, we don't have enough experience to truly know how much money we're saving. And so those rates next year could end up being a little bit higher, which would require more investment from the state. And then there's also Medicaid expansion, which I'll talk a little bit more in a second, is the woodwork effect. So woodwork essentially, is basically the term that because there's increased outreach, increased attention to the program, for whatever reason, that people who, for whatever reason, had never applied before, go and apply, that they're actually currently eligible for Medicaid. And why that is such a big deal to the state is because if you're currently eligible, then the state has to pay 50% general funds for that person, as opposed to if you're eligible in the expansion population, the state only pays 10%. That's a big difference. So they're eligible, so we'll pay for it, but it's just the idea of recognizing the impacts of that in your budget process. So, and you can see that the actual official estimates only assume 1,000 people will be picked up. But when you actually look at a variety of different sources, we can see that there are as many as almost 30,000 adults who are already eligible for the current program, as well as roughly 40,000 kids that are already eligible. So if you pick up even a chunk of those, we have not currently recognized that in our budget, and we would probably see that in the next budget cycle. So Medicaid expansion. So this is actually the official projections that come from the state Medicaid agency, and essentially on January 1st, they were projecting to have about 256,000 enrolled in the program. The actual enrollment report that just came out has it at 198, so they are a little bit behind. But that's part of that is just because Medicaid enrollment, getting people enrolled takes a little bit longer than the time frame they'd already had. But they've done a lot to try to expedite enrollment. They are projecting by the end of the biennium to be at about 375,000 individuals enrolled in the expansion population. So I won't go into great detail about this chart. This is just the Medicaid expansion costs and savings for Virginia. So you have the coverage costs, everything that's state cost. The only issue is the 1115 waiver, which is where you do a work requirement and premiums and other things that are part of this, that whether or not the hospitals pay for that or the state pays for it is one of the issues the General Assembly will have to resolve kind of this session. So the administrative costs for DMAS and DSS also includes, for DSS, that's actually primarily for local eligibility workers. So that might be something that you are familiar with. That money was, I think for the current fiscal year, was about $21 million in total dollars. Most of it's federal that were distributed. I think it created somewhere like 300 plus eligibility workers in local departments. The positive thing ended up being too that the local match for those workers, for the first year the department used other resources to cover the local match for the localities. But going forward, that policy will continue just because essentially the problem that becomes is since the hospitals will be paying the state share, even of administrative costs, if you continue the local match, then localities will pay their share, the hospitals will pay the state share, and to some degree you could argue that just seems a little unfair. So the idea is that going forward for the Medicaid expansion related costs, there's complexity in it and how you do this at the local level and for the State Department to administer that. But that policy should continue that there will be no local match in the Medicaid expansion piece of eligibility. So you can see where the savings comes from for the state, the care savings, there's the behavioral health services, that's the community services boards, the amount of money that was assumed that as their clients transition to Medicaid, where you would have state savings there. There's also the cost of state inmates. This actually affects jails too. If you actually go to the trouble, and there actually are things the state are doing with local and regional jails to help expedite their ability to enroll inmates that could be eligible for Medicaid. But it's only for their inpatient hospital services. That's the only thing that Medicaid will pay for. And then there's just some other certain coverages that switch between current eligibility and the new eligibility. So there's about $370 million in savings, general fund savings, about $380 million in cost. The cost is a little bit higher than originally projected because of the expedited enrollment projections. Actually, so with that, it's like that's Medicaid in a nutshell. You know what we're doing there. Like I said, the main reason I bring it up is because it is one of the primary budget drivers in the state budget, and that's kind of what puts us to where we are. So if there's any questions about that, let me know. Otherwise, I'll move on to a few of the other areas. Yeah.
Hi, thank you. Two quick questions. Just for clarification, you said for the inmate population, Medicaid will pay for them while they're inside the jail facility itself, but if they have to take them out of jail and send them to a state hospital or somewhere else, they're not eligible for Medicaid. Did I get that correct?
It is when they go out into a hospital in an inpatient setting, Medicaid will pay.
But not while they're inside the facility, the jail itself.
You mean being incarcerated? Yes. While they're incarcerated, yes. Now, it's not every inmate. You still have to qualify for Medicaid.
Right, I understand that.
Yeah.
So it covers them while they're incarcerated, and
While they're
it also
incarcerated.
covers them if you have to send them to, say, a state hospital, like the mentally ill, the SMI.
If you send them to the state, no, not a state hospital. It has to be a regular private acute care
Regular
hospital.
private hospital. Okay, thank you. And then the other question I had real quick on the Medicaid piece, the recent court decision in Texas on Medicaid where they threw out that portion about people having to have to buy, and they said it made the whole thing moot. Is that going to impact expansion in Virginia?
Well, I mean, that decision is being appealed, so, and the judge has kind of stayed any impact from it, so it'll have to go through the federal appellate level. Whether or not it goes to the Supreme Court, no one would know at this point. So right now, it has no impact. If ultimately the courts sustain it, then yes, it throws the entire Affordable Care Act up in the air and Medicaid expansion as well. And of course, you'll have a huge, massive national problem. So, but as of right now, it really has no impact on what the state is doing.
Okay, thank you.
So this slide, this has been something I think a big issue for a lot of localities, is in our Children's Services Act program, is private day special education. So when you look at the CSA program overall from a state perspective, when we had changed different incentives for community-based services, CSA was actually declining until about fiscal year 13. And then it turned around. And the reason why is because the private day expenditures of the program started to dwarf everything else in its growth. And you can see, and this is all private day, the number of youth that we pay for, which in just this past fiscal year grew another 300, roughly 300 kids. And then, and this is, of course, this is total state and local funding on the right side. The private day grew another $18 million from FY17 to FY18. So this is, it's an issue for both the state, certainly for local governments. I know, local governments, it's even more complicated because it's an issue between, the county or city government and their school division. Because, and I think, the issue is, I can tell you from working in the last couple of years, that I've even come to the conclusion is like, that this is just not something in the world of CSA and health and human resources that we can just fix. Because it's a special education issue. And so there's a lot of collaboration that's required to sort of kind of address this issue. But it is definitely kind of a major issue that we've been looking at. And that's why I want to summarize here. So when the expenditures started to go up, the Commission on Youth at the state level did a 2-year study in 2014 and 15 and looked at kind of the issue and made sort of recommendations, but nobody, nothing really happened. Then the General Assembly actually directed the State Executive Council of CSA in 2016 to develop additional options for the General Assembly to consider. And it's one of those things that their ears did not perk up until they had to put $88 million over the 2 years into the CSA program. Then all of a sudden, the legislators were like, we've got to fix this. We have to do something, even though we've been talking about it for years. So anyway, so I can tell you myself and some of my colleagues in the House Appropriations Committee have been working on this for 2 years. We're going to continue to work on it. I will probably be retired at this rate. But we are looking at it, and this is something, and we've actually been out to a lot of localities, met with a lot of localities, so this is, we get to, we're right, I can tell you from our perspective, we're right in it with you because, the state's paying 2/3 of these costs. So anyway, so we did create this work group on private day outcomes, because that's one of the things that we don't know. Like, all right, these kids are in a private day school, but are their behaviors improving? What's going on with them? So we actually did direct and they did a work group, and now we've got to go to the next step where we actually implement and start collecting this data so we can actually see what they're doing, whether they're performing well. And that's something that I think both localities and school divisions and the state all needs to understand. There's also a rate study of cost of private providers, just to kind of make sure, like, are our costs in line with what other states do, how it's funded, and that process has actually started, and the report is due in probably the summer of 2019, I believe. The last thing is, I don't know if this has been finally approved, but JLAR may do a very deep, broad study of special education, which apparently they've never done. And what I can tell you is, it really needs to look at the needs of special education, and are there more things that the state can do, I think, ultimately to help local school divisions provide programs and services to keep a lot of these kids from having to be sent to a private day school. So there's a lot going on. The issue certainly has not been resolved, and certainly we'll have to definitely continue to work on it. Sir?
Is there a 2% cap on the annualized growth that was put in place? And if I'm right, are they going to do that again? Or?
To be frank, the cap was sort of put on because they wanted savings. So you probably often know that probably happens at the local level. Just do something. But the theory behind it too is actually that we were going to do this rate study. And if you actually look at like the average cost per kid in these schools, it's actually averaged about 6% a year. And there could be a lot of reasons for that. Hopefully the rate study will share like what goes on and drives those costs in a private school. But the idea really was just, well, at least temporarily, let's just slow it, a part of it down. I mean, that's just the main driver of the number of kids. Because when you look at certain areas of the state, they don't actually see the average cost per kid change a lot from year to year. So they're private, so those schools aren't necessarily raising their rates rapidly. But other parts of the state, they are. So there are different things going on in different places. So hopefully the rate study will shed a lot of light on that. I mean, I don't think that the cap will, I don't think it'll continue beyond that 1 year. I know that we've heard that some localities were concerned about whether or not the cap could shift costs back to them. The language is written such that they're not supposed to raise it for either the locality or the state. And I think from a state perspective, I mean, we'll ultimately see what happens. I mean, the private schools are going to try to get it reversed, of course. They're going to submit budget amendments and lobby the General Assembly to reverse it this year. I don't think that they'll be successful just because it's just too big of an issue, and there are certain legislators that think we have to figure out some way to control costs in those services. So but I don't think it'll be a permanent thing. I think it's just temporary, and hopefully in the next couple of years we'll be developing even better strategies in those services. So I would just touch base in talking about community services boards. Back in the 2017 session, the General Assembly passed a law that basically said we're going to provide certain these list of services that the law requires and the dates of implementation. So you may be familiar with same-day access for CSPs was the idea that you can at least be evaluated on the day that you contact the CSP. Primary care screening and monitoring, behavioral health crisis services, and outpatient behavioral health. These were added in this past year. So this is now over, I think it's over $30 million of additional state funding every year to help the CSPs with these services. The idea to produce this continuum of care. I think we have heard some issues. I think some CSPs are concerned about how the State Department is allocating those funds. We actually have a new special unit at JLARC, and one of the things that they've been directed to do is to look at all the funding streams at behavioral health and see how they're allocated. So that'll probably be an ongoing discussion about what's the most fair way to allocate those funds. Because the CSPs, as you all know, are very different. Now, whether or not we will meet the 2021 deadline, when this law was passed, there were estimates that the annual cost of the state could be as high as $200 million. It would be less now because Medicaid Exchange you could pay for some of these services. But the point being is, it was to some degree aspirational. Let's just push ourselves to try to do as much as we could. And fortunately, the General Assembly has had some resources to continue to do that. So whether or not that continues, we'll have to see. It's likely some of these other services may be pushed out a little bit, but that just remains to be seen based upon how budgets go forward. To talk about CSB funding, where there are concerns, the Medicaid expansion savings, the actual estimate, the savings estimates for this, the estimates themselves were actually developed years ago, and they weren't really updated a whole lot, partly because this was as you know, year after year there was no expansion, so there were certain parts of the numbers that were just never looked at. And so there is stuff that's behind this, like when we provided a limited benefit for certain individuals in Medicaid for mental health services, where Medicaid picked up some of those services, and that wasn't factored in. So I don't think that the original estimates were necessarily perfect, but I do know that they were conservative. But I also know that from a CSB perspective is anytime you shift from a direct appropriation where somebody just writes you a check to I actually now have to bill six different companies to get money, it's like I would prefer the check. So it's like you're shifting to a billing model in which now you have to deal with these six companies. Which is what I talk about next is when I talk about managed care programs, both of the managed care programs now cover behavioral health services. So any CSP that provided Medicaid behavioral health services is now billing potentially six different companies. And if you know anything about insurance companies, you know they all have different ways that they want to do things. And so as this starts, you have billing lags. This is not unusual in any program like this. For nursing homes, we have the same problem. There's these billing lags, and it takes time to work them out. But it is a new way. It's a lot more money that's flowing through this mechanism. And so those issues, as they deal with them, can be very disruptive to any organization's cash flow, and it definitely is to CSBs. In some situations, it could be more disruptive or more of a problem for a CSB than even the reduction from the Medicaid expansion savings. Kind of just the last thing I'll talk about is in social services, the Federal Family First Prevention Services Act, which the state is certainly working to implement. The governor did put in 6 positions for the State Department of Social Services to have to implement the program. There's a large, multiple work groups and stuff that are working this from a protected position. As you know, this is the first time that the federal government's going to allow federal funds to pay for foster care prevention services. So it's kind of a sea change in how the feds operate. But one of the big things too is that it's going to be focused on evidence-based services, which to a large degree may not be provided actually in the community right now. So this is one of those areas where the state may have to look at providing some assistance to providers to switch to some of these evidence-based programs and to set up whole services to kind of move the system that way. It's going to take many years to do it, but you might hear about it because your local departments of social services and from that foster care perspective, certainly this will be impacting them over the next few years as well. I want to, in talking about foster care, JLR just released the foster care report in November, where they noted some of the issues. Not all the issues were new, some of them were long-term issues. And there will likely be actions in this General Assembly for a variety of things, but there could be new requirements that come out of that. There could be additional requirements for training, which as well as even staffing standards for foster care workers and stuff like that. So those will all be parts of those discussions. So with that, are there any questions?
Like one of the big issues that foster reform was the low pay keeping people working in the system, local DSS funds, and that's what you're storing the length of that's one of the problems.
Yes, it is a major problem. I know the department had requested additional funds to try to bring the salaries up of some of these local workers. It wasn't funded in the governor's budget, so that would be an ongoing issue. And I think that even on top of that, from a workforce perspective, from what we hear, it's a struggle enough to get these people, but oftentimes they come in and they need them to work, like right away. And of course, I can't even imagine being a foster care caseworker and what you have to deal with. So you could have these young people that you just kind of throw them into this. They don't have all the training that they need. They don't necessarily even have the right supervision. That's what the kind of report highlighted. And these are things that we need to address. And even if we can't do much with compensation as of yet, I think from my perspective, I think training would go a long way. The state has been awful for a long time. It's the first thing that's cut in the budget cut. The unfortunate thing is, for a system like this, it's unbelievably important. So training, trying to get more supervision in that system is absolutely critical. We'll continue to look at it, but there may be some action discussion on that. So are there any other questions?
Have you seen a tie-in with the foster care program driving the CSA rates up?
Actually, yeah, that is a recent issue that was brought to our attention that just started this fiscal year. So what you see in the governor's budget is actually about $6 million a year in savings, because even though the private day part of CSA is still going up, the other services actually, for the most part, are growing slower than projected last year. But the one piece that they've seen in this fiscal year that's going up is basically non-4A, which is the federal foster care program, which CSA pays for those foster care. And they believe it's heavily related to the opioid epidemic, because the opioid epidemic is not limited to just low-income individuals. You're reaching people who are above the federal income limits. So they're seeing that. I think the first quarter, they saw $4 million in total expenditures. greater than the same of the previous first quarter. So that's something that we have to look at as well as discussion to see if that's sustained and whether or not we have to make adjustments in the budget for that. But yes, we are seeing that increase. Any other questions? So, I mean, is anybody hearing a lot from their CSBs? No? Anything that I didn't talk about that?
They're asking for mortality.
Right, to offset, right. Right. Which, you know, like I talked about, even with like the managed care piece and stuff like that, I mean, they could probably make an argument that, well, until a lot of these things are worked out, you know, we at least need a buffer. And I don't know how you would do that at the local level. I mean, the one thing I did not talk about was that and y'all are probably already aware of this, but the budget does include this special fund of $7 million. It comes from special funds from the Department of Behavioral Health. Their special fund revenue comes from the training centers, which even though they're closing, it still has a lot of money still left in it. So they've set aside $7 million to assist CSBs that if you meet their methodology, which is fundamentally that if it's 10%, I think if it's 10% greater than what was otherwise projected, you can access this fund. But I do know there are issues with it because it sort of happens after the fiscal year, which, you know, from an operational standpoint, it sort of makes sort of sense because you have to have all the information first to really understand how it impacted the CSB before, I'm sure the state wants to make a determination whether or not they give you any money. But from a CSB perspective is, if you don't have enough money to make your payroll, that's a major problem. So that language may have to be tweaked just to keep things afloat. I do know that the state Medicaid agency has, from the managed care payment standpoint, has kind of softened, I don't know exactly what you call it, but their authorizations and stuff for behavioral health services to make sure the money is flowing a little bit faster to CSBs. So I think they started that January 1, so hopefully that helps them as well. But we've definitely heard a lot of concerns as well.
Mike, could you talk a little bit about the mental health and jails issue, you know, the pilot program, where that is, what do you think might happen there? The whole issue of mental health and jails.
You mean like the $2.5 million for the pilot programs, or?
Where is it, you know, it's gone here already, hasn't it?
Yeah, there's money in the governor's budget to continue.
Right, have you learned anything from that? I mean, what should we do about mental health in jails? I mean, it's a huge issue.
Are there any easy questions? Yeah, I'm with you. You know,
That's why Jim sits on the front row.
he asked the right questions.
Nice to have that answer, but let's just a conversation.
Of course, I have all the answers. That's what people always look to me. Yeah, so from the high level is, step again, you want this robust system of community-based services. Yes, we're probably, God knows how many years away from it. But we're moving in that direction, that's great. So if you have a community-based system that can provide mobile crisis and a variety of services to intercept people before they ever reach the jail, you know, that's ultimately where you want to go. It's going to take time to get there. Now, you're always going to have mentally ill people in the jail. Sometimes they're going to commit serious crimes, and we can't just say, whoop, you're mentally ill, so there's no, you know, you're not responsible. They're going to end up there, so jails, to some degree, probably need more services, as you well know from some of your past experience. The funding of jails from the state level is pretty low. So whether or not the state will ultimately do more there, I don't know. But the one movement is, and this is not related to the pilot projects, is this idea of creating minimum standards for the jails to meet for mental health. I think that will be a bill that year. That definitely looks like that's probably moving forward. I don't know at this point whether or not there are jails that would require substantial resources to meet those standards or not.
Here's an idea actually that Neil makes that tie the jail per diem to a certain degree to the number of mental health identified people you have in it, so that it provides more funding for those with higher levels of, you know, people with problems. So you adjust that jail length.
Yeah, that's probably something we should think about. But no, that's a hard question, but ultimately, a much better community-based system is going to go a long way. It's just that we're going to have to do a lot of the meantime to deal with that. So, back there.
Hey, Mike, I'm gonna let Sherry go first, so I'll go after her.
He doesn't like my questions.
I like all questions. I don't like talking at people.
No,
So.
as I work for the city of Portsmouth, and we have the Hampton Roads Regional Jail with the highest number of SMI inmates in it in all regional jails. So I second that emotion that Jim Reginald just gave you on the jail per diem. But my question was, the funding that you mentioned for the CSBs, that you said if they're more of a 10% loss and they cut, they can apply to get these funds. How do you go about getting this funding?
What was the end of that?
How does one get the funding?
Oh, I'm assuming that the department will create some process. I'm sure they'll consult with the CSB Association to do that.
Okay.
At this point, I don't know. I mean, I'm sure it'll be, right now it's just a paragraph proposed in the budget. There's a lot of details that are worked out because what type of data are you going to use to verify that? Because that's going to be the problem. It's going to require the state data about who's eligible for Medicaid, data from the CSBs, all of this, and how you do. I mean, that's part of the problem is how you do all this in a timely manner to make sure that the CSB is funded so that they don't run into major problems. So that's just something that we're going to have to think about this session to figure out what's the best way to do that. So if you have any ideas, we're more than welcome.
Thank you.
You'll know where to find me for the next 45 days. One building I don't leave. So.
Gotcha.
Mike, could you speak to the TANF fund balance and what that is looking like as we head into the session?
Yeah, but if I answer that, then Jim's going to get on me. The TANF fund balance. So I think it's at almost 130 million, roughly. I don't remember the exact number. It's very large. We looked about it, and probably, I think that's one thing. I was surprised to actually see that the governor did not promote. He really proposed money for $3 million a year to fund food banks. I was very surprised that he didn't. There was no proposal to increase the benefit rate, stuff like that. Well, this is the week where members submit budget amendments.
Yeah.
So I can already tell you that the TANF stuff is pouring in. So when it comes to TANF, I'll admit my credibility is out the window now. I've been saying for years that the problem with TANF is, and it will still happen, if you go into a significant recession, TANF has to be used for its mandatory purpose, which is cash assistance, the mandatory purposes of TANF. And it very quickly, if the caseload skyrockets, it will quickly consume everything. The fascinating thing about TANF is that we received the same amount for when TANF reform occurred in 1996. It's a $162 million grant that the state gets every year. It has not changed in over 20 years. The number of people we serve, and I don't have the exact numbers in TANF today, the caseloads compared to what it was prior to welfare reform in the 90s, is a tiny fraction. We have definitely moved people away from cash assistance. So what we use TANF for, we're definitely, in recent years we have invested some of that money in local governments where they have ideas of how to do more innovative things in poverty, something that the General Assembly really likes that. And we're hoping that great things come from that, and we have TANF and other funds to use to continue to fund those things. But TANF will definitely be, I would not be surprised in this session if there isn't an increase in the actual TANF benefit, and there will be a whole host of ideas from members on how to spend it. And we should at this point. The balance is so large that we need to use it to do something good.
Yeah, we'd love to help.
Well, this is budget amendment week. We got till Friday, 5 p.m.
You're right.
Right.
You mentioned earlier about the policy of no local match for continued PCSS or Medicaid expansion. I just wanted to clarify this. Would you just in 2019 say now the expectation is full time? You would have to pay a local match in 2020, if not.
it is my understanding from the department that, that for the Medicaid expansion part of eligibility, and of course, and I recognize that that adds complexity in how they account for things, so I don't exactly know how they're going to do that, but you know, I'm sure they got a lot of smart people who figure that out. And but no, it will continue. And I know the department, they're a little bit confusing at first because, well, one, and I'll be honest with you, as a budget person, the department all of a sudden decided, well, we came up with these sources to waive the local match. It's sort of, as a budget person, my first reaction is, you did what? It's like the state's putting up all the money? It's like, so, but as we thought about it more, that was the issue. Because going forward, if the state has no match, the hospitals are paying for it. So why are we expecting the locals to pay their local match for this piece when technically the hospital should be paying for it? So that's really where that comes from. How you actually operationalize it and reimburse the locals to do that, that's probably going to be a little bit complicated. But from the General Assembly's perspective, that is kind of the intent. And that's our understanding from DSS, the State Department as well. If you ever hear anything to the contrary, let us know. They may not have sent out a memo to everyone yet because maybe they don't know how to operationalize it or something. But in their discussions with them, that's what has been happening.
Okay. We called them a couple months ago, and that's what they said, that we would have to pay local match for 2020.
Yeah, at that time, they were thinking that, and then I can tell you, I had conversations with some other counterparts to say, wait a second, they don't need to ever pay, the hospitals are going to pay for this. Hospitals may not like that, but it doesn't seem fair to me that the state doesn't have to pay anything for these local workers, but the localities do. So but yeah, if you ever hear anything different, let us know, because that's not the intent.
Who hasn't heard something different?
Well, like I said, it's like they probably haven't gotten to, how a system like that goes about eventually, I don't know if they send out memos. In Medicaid, they send out memos to people. They call them Medicaid memos to providers, but I don't know how the State Department does that. And what I'll do is I'll talk to the commissioner and just make sure that that's their understanding, and maybe they can communicate that to the localities. Because I understand they can, it's like, as local governments are funding these eligibility workers, that's one of the questions, is how you use the local share. So from a budget perspective, we all need to know that. So I'll check with them and make sure that's communicated. He may be waiting for the General Assembly to put in language to say this is the policy so that he doesn't go out on a limb. I'm not sure, but I'll talk to him about it. Thank you all very much.